Good day. We will be picking up our discussion of pulmonary blood flow with the following slides. So first, the pulmonary arterial vessels have larger diameters. They are thin-walled and distensible, making the pulmonary arterial tree have a large compliance. So what does that mean? Remember that the right ventricle pumps its blood, the deoxygenated blood, into the pulmonary artery, where as they come in contact with the alveoli, gas exchange occurs through alveolar capillaries, and that oxygenates the blood. So the pulmonary arterial tree carries with it deoxygenated blood. So, when we say that the pulmonary arterial vessels have larger diameters, we mean that if you cut the artery in cross-section, you will have a larger cross-sectional area. So, more blood can flow into that larger cross-sectional area. They are thin-walled and distensible. That means if force is applied to the walls of the pulmonary artery, it will stretch. And so that will make the pulmonary arterial tree have a large compliance. So what is the importance of the large compliance? It allows the pulmonary artery to accommodate the output of the right ventricle. So whenever the right ventricle contracts during systole or ventricular contraction, all of the blood that it holds, almost all of the blood that it holds, will go into the pulmonary artery. And that is a lot of blood. And so if the pulmonary artery does not have compliance, as the right ventricle pumps, the pressure inside the pulmonary artery will increase. And so the compliance of the pulmonary artery is there so that even if blood flows through it, a lot of blood flows through it, the pressure inside will not increase as much. There is also another source of blood into the lungs. Blood also flows to the lungs via the bronchial arteries. These arteries are on the surface or walls of the bronchus itself. These arteries carry oxygenated blood amounting to 2% of the total cardiac output, meaning for each minute that the left ventricle pumps, how many beats it makes in a minute, and the volume that is pumped with each beat, that's the total cardiac output. 2% of that will go into the arteries that are found on the walls of the bronchus or bronchial arteries. But because the blood comes from the left ventricle, it is already oxygenated blood that goes into the bronchial arteries. Contrast that to the pulmonary artery, which carries deoxygenated blood. However, afterwards, the blood from the bronchial arteries are drained by the same pulmonary veins, which goes into the left atrium. And this decreases the total oxygen to be supplied to the systemic circulation. Remember that in the alveolar capillaries, gas exchange occurs and the blood becomes oxygenated. It returns to the left side of the heart via the pulmonary vein. And so the pulmonary vein carries oxygenated blood, but because the bronchial arteries, which have gone through the walls of the bronchus and supplied blood and oxygen there, are now being drained into the pulmonary vein, the carbon dioxide and the blood, now with low oxygen inside the bronchial arteries, mix with the oxygenated blood in the pulmonary veins. And so the total oxygenation decreases after the bronchial arteries are drained. So again, this is a picture showing to you the dispersion and the formation of smaller generations of bronchi as well as pulmonary arteries. So first, let us orient ourselves. This is the pulmonary artery from the right side of the heart. As it goes deeper into the lungs, it divides, and eventually, it comes in contact with the alveolus, which contains air inside, and the pulmonary artery at that level, surrounding the alveolus, now becomes a pulmonary capillary. And because the pulmonary capillary is very thin-walled, gas exchange occurs, and the blood is then drained by the pulmonary vein, which is now oxygenated. And the pulmonary vein will go into the left side of the heart, left atrium, left ventricle, and then into the aorta to supply oxygen and blood to the rest of the body. Now, what I want you to notice is that this one, the airway or the tertiary bronchus, progressively divides to become smaller and smaller airways until it reaches the terminal bronchiole. And as you can see, on the surface of the terminal bronchiole, there is this artery. If you follow the cursor, this is called your bronchial artery. And this bronchial artery, the blood inside comes from the left side of the heart, meaning inside this one is oxygenated blood. And as you will notice, as it goes together with the bronchial tree, supplying oxygen and blood to the bronchial tree, the venous drainage will be through the pulmonary vein. And so, after giving of blood to the bronchial walls and tree, the oxygen inside it will be siphoned out by the cells. And so, what leaves the blood vessel will be deoxygenated blood. The pulmonary veins carry oxygenated blood. Mix that with the deoxygenated blood from the bronchial artery, and you will decrease the total oxygen in the blood that goes back to the left side of the heart, to the left atrium. The lymphatic ducts remove some of the particulates, meaning dust, carbon, mineral particles suspended in the air that you have inhaled deep into the alveolus, as well as plasma proteins leaking into the alveolus from the alveolar capillary. So, I want you to remember that the alveolar capillary, the capillary around the alveolus, is filled with blood. And blood is made out of formed elements, the cells, red blood cells, white blood cells, and platelets, and plasma. So, suspended in that watery plasma are plasma proteins. So, there are plasma proteins that leak into the alveolus, meaning from the alveolar capillary, the proteins and the water will go cross the wall and enter the space inside the alveolus. If the particulates, the dusts, and the carbon and mineral particles, together with the plasma proteins and the water, are not drained, they will accumulate inside the alveolus. And that will decrease the space for air and also decrease oxygenation. Okay? So there has to be a way that the body has to remove these particulates and plasma proteins. And so that is the work of the lymphatic ducts. If the lymphatic ducts are overwhelmed, they are not able to remove these particulates and plasma proteins, pulmonary edema will occur, meaning the space inside the alveolus will be flooded with fluid. And that fluid will increase the distance that the gases will have to diffuse to. And that will prevent oxygenation of the blood. So this picture will show you the gross or macroscopic lymphatic channels and lymph nodes. So first, I want you to follow the cursor. And as you can notice here, you have the right lung and the left lung. The right lung has a superior, a middle, and an inferior lobe, whereas the left lung only has a superior lobe and an inferior lobe. So follow the cursor. The first lymphatic channels that will actually drain the alveolus, the first macroscopically detectable, meaning you can see it with your naked eye. The first lymphatic channels would be the interlobular lymph nodes or lymph vessels, sorry, interlobular lymph vessels. The interlobular lymph vessels will fuse with each other up until they encounter detectable bronchi. So the drainage follows bronchi, arteries, and veins. So interlobular lymph vessels, they will fuse and become larger, and they will associate with the actual respiratory tree, which is the bronchi. Okay? Next, the lymphatic vessels here will drain into the following nodes. The first nodes that are encountered are the pulmonary nodes or intrapulmonary nodes. And then there will be efferent lymphatic vessels from these nodes that drain to the next set of nodes called hilar lymph nodes or bronchopulmonary lymph nodes. So from interlobular lymph vessels, the vessels become larger and drain or encounter the first set of lymph nodes called intrapulmonary nodes. And then the fluid inside the intrapulmonary nodes will go into the bronchopulmonary nodes or the hilar nodes, meaning the lymph nodes are found in the hilum of the lung. And then from there, they will drain into the tracheobronchial nodes. So your tracheobronchial nodes are situated where the trachea divide into two bronchi. So you have an inferior tracheobronchial node and a superior tracheobronchial node. So the inferior tracheobronchial nodes here are also called the carinal nodes because they are situated beneath the carina, which is the point of division of the trachea into two bronchi. So you have here the inferior tracheobronchial nodes or carinal nodes. And then from there, it will go into the right tracheobronchial nodes, okay, superior tracheobronchial nodes, and then into the paratracheal nodes, meaning para means around. So it is around the trachea, paratracheal nodes, and then eventually it will drain into the inferior deep cervical node, meaning it is at the inferior portion of the neck, deep within the neck, inferior deep cervical node. And from there, it will drain into the venous angle through the lymphatic duct, which is this one. And what happens? The particulates the plasma proteins, and even the microbes that are inside the alveolus. They will be drained by the lymphatic vessels. And as the lymphatic vessels go into the lymph nodes which contain white blood cells, in particular macrophages, will continue to phagocytose these debris. Okay? And so as more and more lymph nodes are encountered, the drained fluid becomes cleaner and cleaner up until it enters the superior vena cava, where it will mix with the plasma of the blood. The systolic pressure in the right ventricle averages 25 mercuric millimeters, and the diastolic pressure averages 0 to 1 mercuric millimeter. So when you say systolic pressure, that is the pressure inside the right ventricle when the right ventricle contracts. So the reading averages 25 mercuric millimeters, meaning when the right ventricle contracts, the pressure inside it is 25 mercuric millimeters. And when the right ventricle relaxes, the systolic right ventricle pressure, the reading will be 0 to 1 mercuric millimeters. These values are only 1/5 of the left ventricles, meaning the pressure inside the right ventricle is only a fifth of the pressure that you will normally encounter inside the left ventricle. During systole or ventricular contraction, the pressure in the pulmonary artery is equal to the right ventricle. So what does that mean? When the right ventricle contracts, you will observe 25 mercuric millimeters of pressure inside it. That pressure, 25 mercuric millimeters, is also observed or is also the pressure in the pulmonary artery. Okay? But remember, the pulmonary arteries are distensible and are compliant. Therefore, they can stretch so that with that amount of blood flow from the right ventricle and that amount of pressure, no further pressure uh, will be added into the blood because the pulmonary artery stretches with the force of ejection from the right ventricle. So no increase will be found. This picture shows the pressures in the right ventricle, pulmonary artery, and the aorta. Remember that the right ventricle and the pulmonary artery are part of the pulmonary circulation. So the pulmonary circulation is classically described as a high flow, low pressure circulation, meaning a lot of blood will go through it, but you will not see normally a very high pressure. Okay, high flow, low pressure circulation. So as you will notice, during right ventricular contraction, the pressure in the right ventricle and the pulmonary artery will be touted at 25 mercuric millimeters. So that is the pressure during ventricular contraction of the right ventricle. As you will notice, during the same time, remember that when the heart beats, the ventricles will beat at the same time. The right ventricle will beat at the same time as the left ventricle. So when the right ventricle contracts, the left ventricle will also contract. And so that will also generate pressure. But take a look. At the aorta, the pressure reading during left ventricular contraction will be at 120 mercuric millimeters. Contrast that to the pulmonary artery, another artery. The pressure is only at 25 mercury millimeters. So what does that tell you? The aortic pressure, which is the pressure read by a systemic artery, is 5 times higher than the pressure read in a pulmonary artery. Okay? So what does that mean? If the pulmonary artery is a high flow, low pressure circulation, the the aorta is a high flow, high pressure circulation, meaning it is not as distensible and not as compliant compared with the pulmonary artery. That is why when blood flows into the aorta, because it does not stretch as much compared to the pulmonary artery, the pressure reading will increase. It is difficult to measure left atrial pressure directly. Thus, what we do is only estimate using a technique called the pulmonary wedge pressure. A Swan-Ganz catheter is inserted through a peripheral vein at the right side of the body, and that peripheral vein again is connected to the right side of the heart, and so the Swan-Ganz catheter from the peripheral vein eventually finds its way into the vena cava, into the right side of the heart, and into the pulmonary artery where it is wedged. So the catheter is continuously being introduced up until it will not move forward anymore. And the pressure there is red. Okay? So the reading at that point will be the estimate of the pressure in the left side of the heart, particularly the left atrium. So this is how it looks. You start inserting the catheter into a peripheral vein, and that catheter is continuously being advanced into the right atrium, into the right ventricle, into the pulmonary artery, and into the branches of the pulmonary artery inside the lung, where if you are not able to move the artery anymore, you have wedged the artery and you get the reading there, and that will be an indirect estimate of the reading in the left atrium, the pressures in the left atrium. So why is this important? Because there are diseases where blood flow uh, produced by the left ventricle contraction decreases. And so there will be backing up of the blood from the left ventricle into the left atrium. And from the left atrium, if this is already flooded with blood, the blood will backflow into the lung. And so a patient might manifest with difficulty of breathing. Okay, because the lungs are being flooded with blood. Why is the blood flooding the lungs? Because it is not being pushed forward. Okay, and so this is a good estimate uh, of the ability of the circulations, the right circulation and the left circulation of the heart to continuously move the blood. So this picture will show you the pressure differences in the vessels of the lung. So this reading right here is for the pulmonary artery. During contraction of the right ventricle, during systole, the pulmonary artery has a reading of 25 mercury millimeters. And then this will be at the point of relaxation. And as the pulmonary artery continuously branches to become smaller, what you will observe is that the excursions, the going up and going down of the pressure reading decreases up until you reach the point of the pulmonary capillary, where the mean reading or mean pressure of blood inside the pulmonary capillary will be around 8 mercuric millimeters. And at the left atrium, it is around 2 mercuric millimeters. Okay? So, um, this is the usual reading using a Swan-Ganz catheter advanced via the pulmonary wedge method. So the usual reading is around 2 mercuric millimeters. So let's say, for example, your reading is 10 mercuric millimeters. That means the left atrium, the pressure inside is higher than normal, meaning blood is continuously damming up in the left atrium and not moving forward. Or the left side of the heart is stiffer than usual. That is why it does not stretch and the pressure increases.